Thank you for downloading Children's Pedcast. I'm Jimmy Bellamy, and this week my guest is Dr. Doug Hyder, the Medical Director of Pediatric Neurology at Children's Hospitals and Clinics of Minnesota. Dr. Hyder is here to talk about headache management, and we talk about specifically how to treat headaches in children. We talk about all of the factors that could come into play in causing a headache, what the triggers are. There are a lot of factors as well that are connected to head pain as a symptom, things that are ongoing in a person's life, how you can make certain changes, and how we treat them here at the neurology clinic. You can find us on the web at childrensmn.org. We're on Twitter at childrensmn. So sit back and enjoy the show, Headache Management with Dr. Doug Hyder.
Pretty good.
I am recording. You nailed it on the first try. So when you break it down, people come and see you when their children are experiencing headaches, having issues with them. How do you treat it? Especially since I imagine everyone is unique, and is it true that no one headache is the same, or is that not true?
There's hundreds of different causes of headaches, and one of the important jobs that we do is to try to sort out which of all these different potential causes, what is actually causing the pain for this particular individual. Broadly speaking, those diagnoses fall into two categories. The first category are called primary headache syndromes, and the second are secondary headache syndromes.
With that, are there more common ways that you see as far as what people are experiencing symptoms-wise? Are people coming in frequently with X, Y, and Z symptoms compared to others that you see less frequently?
The most common scenario that we see is where the person experiencing the headaches has a number of other medical and social issues that are fueling that feeling of pain and discomfort. And so by understanding all of the different components that are feeding in and causing that pain frequently day after day, that's where we can really start to tease out what are interventions that we can take on to decrease the frequency and duration and intensity versus what are some features that perhaps we can't do much about. So, for example, weather is often a factor in triggering headaches. And as much as I would love to write a prescription for all of my patients to move to Hawaii with their doctor, that's just not practical. So we have to kind of take the weather as it comes. But when it comes to sleeping or proper nutrition or getting exercise or getting down to a ideal weight or managing your stress, those are the things that we can help someone with, and again restore them to better health and less pain.
What are some recommendations you have for people to do in advance of coming in? Would you recommend almost doing a lifestyle audit so they are at least ready to say, here's what kind of sleep I'm getting, here's what I've been eating?
They don't have to do that. Part of our intake is to have the child or adolescent or teenager or young adult take us through their day. But you're exactly right. If they can help me by keeping a calendar, by keeping a log, so that I can understand their sleeping habits, their nutritional habits, their exercise patterns, day in, day out, stressors either at home or school or work, that certainly kickstarts the process. we will also typically screen people for anxiety and depression and sometimes other psychological or psychiatric diagnoses as part of a comprehensive intake to try to understand exactly all of the different elements that are feeding into these headaches.
When kids are experiencing, if a child is experiencing a headache and maybe this child has been experiencing them for as long as he or she can remember, is it difficult to measure the degree of severity because this is something the child has lived with?
No. We use routinely something called the Midas scale. This was originally developed for adults, but has been adopted for children, adolescents, teens, and young adults. And essentially what we're looking at is the impact of the pain on their day-to-day life. And the questions in the Midas are: how many days of school are you missing? How many half days of school are you missing? How many days do you just not feel as though you're able to perform up to your ability? How many days are you only able to perform at half of that ability, etc.? And then based on that, we can put people into a mild, moderate, or severe category. So clearly someone who is having excruciating pain day after day and not able to go to school, we're going to address that set of circumstances differently than, say, a teenager who might be having very severe pain, but once or twice a year.
Are you seeing a common age where kids are coming in with headaches? Is it when they're first introduced to regular school? Is it when they're first introduced to athletics? Or does it run the gamut as far as the ages of children that you see?
So for the secondary headaches, those are the ones where the nervous system is working properly and something is going on in the face or head or neck that is triggering the nerves to send a signal to your brain that something's wrong. And that can be any age, whether that's a corneal abrasion or a dental abscess or tight neck muscles. In terms of the primary headache disorders, primary headaches are defined as where the nervous system is overloaded and sending a signal to the higher levels of the brain that something hurts, when in fact there's nothing that we're able to identify that's physically wrong. The pain still hurts, but the sensation is because the nervous system is overdoing it. The sensory system is too sensitive, and it's sending in a signal where a signal should not be sent. The doctor term for that is allodynia. So if we imagine walking outside on a windy day or brushing our teeth or chewing, none of those things should be painful. However, if the sensory apparatus is sensitized and feeling overloaded, those normal sensations are going to be interpreted as painful sensations. For those primary headache disorders, the most common ages are in the high school years. So, and no one knows exactly why. They're more common in 16 and 17-year-olds, and no one knows exactly why it seems to be more common in women than men. But for the migraine conditions, my average everyday patient is going to be a high school girl, and is going to be looking for answers because those headaches are causing a significant impact on her day-to-day life.
What is the difference between a headache and a migraine? I've always wondered, and what I've always gauged, and I don't know it to be accurate, is if all I need to do or all I can do is lie down in a dark room and fall asleep, I consider that a migraine. And that may not be true, but what are the differences?
So a migraine as a medical condition has diagnostic criteria. You have to have more than 5 episodes. They have to last at least a couple of hours. They have to be a fairly severe type of discomfort. They are usually accompanied by what we refer to as autonomic symptoms, so that would be things like nausea or vomiting. Usually, they're accompanied by sensitivity to light and sound. And then perhaps most telling for me, like you mentioned, is that sensation of fatigue, that sensation that I just want to go to bed and pull the sheets over my head and have everybody leave me alone. And if you think about it, that's an unusual reaction to pain. If I trip and fall and skin my knee, chances are I'm going to scream out and jump up and down and, hold my leg and, maybe cry or something like, ouch, that hurts.
You've seen me hurt my knee.
I've hurt my knee plenty of times. However, a migraine is different. You're feeling that pain and discomfort, but the way we respond to migraines is to kind of shut down. And so that's one of the big distinctions that I use clinically to try to differentiate a quote-unquote regular old headache from a more migraine-like headache.
Now, there are many departments within children's where you're dealing with pain or something wrong that you can't see with the naked eye, you can't see on the surface level. But it seems that with headaches, you're dealing with even more of a challenge from the standpoint of somebody can be in excruciating pain, and it's far different than seeing somebody with a skinned knee where I know how you hurt your knee, I know why it hurts. Already it sounds like there are so many factors that come into play when it comes to treatment and management of headaches. Is there a general place where you begin as far as what's at the top of your checklist when you're looking at, okay, first, what are you doing here?
Sure. So the first thing that we do is we try our best to find those types of headache conditions that pose a danger. So someone has, say, an aneurysm or some other type of bleeding, or perhaps very high blood pressure or increased pressure within the skull, increased intracranial pressure, or a brain tumor, or something that is that needs to be diagnosed and needs to be addressed. And that's where we use our interview skills, our questionnaires, and our physical exam skills. I was taught, and I give credit to my teachers out there, that if you don't know what's going on at the end of your history and your physical exam, you should probably go back and get more history or do a more detailed exam. If you're still not sure what's going on, that's when I tend to order diagnostic tests. So we do use MRI scans. Sometimes we obtain spinal fluid with a lumbar puncture. We sometimes have other specialists like an eye doctor or a dentist or an otolaryngologist examine our patients. But the goal is always to try to figure out if that person has one of those secondary headache conditions. If there's a dental abscess, I can give you a pain medicine, but ultimately to alleviate that pain, a trained professional dentist is going to have to fix what's fueling that discomfort. Having excluded those secondary concerns, if we can put that individual into a primary headache disorder, a migraine, a cluster headache, etc., then we go about trying to manage those symptoms. And my goal is to not simply alleviate the pain and discomfort, but to do my best to try to help that person lead a healthier life. And that's where I get the enjoyment out of my job. It's not so much that I'm making people helping people be in less pain, that's good. But if in addition to that, I can also help these teenagers and children and young adults lead healthier lives, then I feel as though I'm doing something more useful for them. So how we go about it then is to try to understand what are the factors that we can modify and what are the factors that we can't modify.
That's interesting. And have you always taken the long-term approach when treating and looking at headache management? Medicine is a quick fix, but that's short-term when it comes to the example of the abscessed tooth. How many patients are coming in, or patients' families coming in, with just looking at that short-term help? Or are they thinking, I'm looking for something permanent, something down the road? Or are they first hearing it from your perspective when they come in?
It's a combination. I think, though, enough of my patients have already had their pain temporarily relieved that they're looking for a more permanent solution. And I don't mean this exactly the way that it sounds, but we can always alleviate pain. Mm-hmm. I can always give you a strong narcotic, or we could even do general anesthesia. We can always get you out of pain. Mm-hmm. But it's not much of a life if you're under general anesthesia all the time. You can't really go to school.
You're giving up a lot if you're living like that.
And I'm using that as
yes.
an extreme. Obviously, we wouldn't do that, but I'm just trying to say that well, if I were writing a book, the title of my book would be "It's Not Just About the Pain." It's with all due respect to Lance Armstrong, it's not simply about alleviating the discomfort. It's almost an opportunity for me as a pediatrician to get you in the office and to try to help you lead a healthier life. And the byproduct of that is that, yeah, you'll be in less pain. But the secondary benefits of now you have the freedom to go to school every day, get a job, hang out with your friends, play sports. The pain control is really just a small part. But I think that most would agree that a long-term solution is going to ultimately be superior than to a short-term fix.
I want to talk about what you mentioned earlier about the overloaded sensory functions. And is it always situational, or are there people who have that permanently, that they're born with it, or through some kind of event they have somehow maintained that?
Absolutely. There's a large genetic component to migraine phenomenon, and from a certain point of view, that's probably a good thing. And for those of you out there listening to it, don't misunderstand me. I'm not saying migraines are good. What I'm trying to say is that our sensory system is designed to protect us. It's designed to alert us that something's wrong and we better pay attention to it, or even worse things are going to happen. So if you think about it as a gauge, the sensitivity of the sensory apparatus is supposed to kind of be in the middle. If we overdo it and you're not able to feel any pain, that's not a good thing. And what we see with folks who have migraine is kind of the opposite extreme, where their system is so tuned in to changes that oftentimes any little thing can kind of set it off. So sometimes I'll phrase this as, it's a good thing your sensory system is working. It's just too much of a good thing.
Too fine-tuned.
It's too easily triggered. And so looking at it from that point of view, now what we're going to try to do is decrease that sensitivity so that the system is able to properly respond when something hurts, when you've got an eyelash in your eye or a cavity or an ear infection or whatever it is. Our goal is not to change that sensory apparatus to the opposite extreme where now you're not feeling any pain. That's not healthy either.
What kind of steps should a parent take when dealing with a child who they suspect has a headache, or child says, my head hurts?
Well, the most important thing is to try to look at the situation. So, for example, if it's summertime and your son or daughter skipped breakfast and they skipped lunch and it's hot outside and they haven't been really drinking very much, but they've been running around all day, and they come in and they say, I'm tired and I have a headache, you do what everybody else does. You sit them down and you let them chill out for a little bit, and some food and some water, and that ought to do the trick, right? There's certainly the opposite extreme where, for instance, let's say that out of nowhere, suddenly you have the worst headache of your life, and that's incapacitating. Well, that's where you really need to go into the emergency room. Or, for example, let's say that someone's fallen on their bike or a skateboard or skiing or whatever, and they seem fine, but then gradually over the course of a few hours, now they're more drowsy, they're more sleepy, they're not answering properly, etc. Again, that's where you'd want to seek urgent care.
And what should a parent do if the child is either too young to convey or somehow unable to convey that he or she is experiencing head pain?
The youngest child I ever saw with migraines was about 3 years old. It was a particularly eloquent 3-year-old who could really explain how she was feeling. Younger than that, oftentimes what parents will notice is a change in the behavior of their child, or a change in their normal patterns. So, for instance, they might be sleeping more or not eating as well. So it might not be clear that it's a headache, but the parents can sense that something's just not right. And in those situations, seeing the primary care doctor, getting a good history, good physical exam is the first step. And then certainly if specialty care is needed, we're here.
It's difficult to put a blanket on anything, but especially when dealing with headaches and head pain. How are you able to separate the for sure methods that work to the this is what works for this person?
Headache management is very pragmatic. So if you were to tell me, for example, that you get a couple of migraines a year and you have a Snickers bar and a bottle of Coca-Cola and that works for you, God bless you, go right ahead. Or if an over-the-counter medication works, if taking a nap works. So if you have an effective method, or frankly, if you know your triggers, for example, some people find that certain foods seem to trigger a migraine. Well, you don't necessarily need to see a doctor. You can manage those things on your own. Where we get involved is where the cause and effect relationship isn't so clear, or people have tried those interventions and they haven't worked, or when things have really gotten out of control to now you've got someone who is experiencing pain daily and they're missing school and it's causing havoc in the rest of the family. That's probably where you're best to see your primary care physician, get some advice, and if it's necessary to see a neurologist, then again we're here, we're available.
Concussions are frequently talked about, especially the past 4 to 5 years. How much has been learned about concussions in the past half decade or even past decade? And maybe that's too vague to say how much, but have we made significant strides in this past decade as far as learning what we know about concussions, or is it just, did it kind of hit that mainstream where maybe doctors have known for a while, but now we're seeing the effects so frequently, whether it's in media or anywhere else, that it's just being talked about more?
There is some very good research going on in what's happening neurophysiologically to the concussed brain. It is very interesting research, and we hope that will help us in the future. However, much of the understanding was put forward 10 or more years ago, and that basic understanding has not changed a lot. You're exactly right. What has changed is the appreciation that it's not just you got your bell rung or you're feeling a little groggy, but in fact, that is a head injury, a brain injury, and should be taken seriously because there can be significant short-term and even the potential for long-term effects. In terms of how we manage concussions, there's really two things that I keep in mind. The first is that whatever symptoms you had before that head injury, it's more likely than not that it's only going to be worse. So if you were struggling in math class, you're still going to be struggling in math class, and it might be even more difficult.
Yeah, that is not, getting a concussion is not the answer to
exactly
learning math.
If you were not the fastest runner on the track team, getting a concussion is not going to make you any faster. So a big part of what we do is try to understand what the pre-injury state was and to what degree the head injury has caused these symptoms or worsened these symptoms, or is in fact just a continuation of what's been going on for years. The second thing that's become very apparent to us is, like much of medicine, it's a lot easier to be healthy if you never get that concussion in the first place. So I like that, at least lately, there's been a much greater emphasis on trying to prevent those injuries. And I think ultimately that might have an impact on which sports our children participate in. And hopefully the goal is to have a healthier population where, rather than trying to treat medical problems after they happen, we shift the emphasis to try to prevent those medical problems from happening in the first place.
Is there a time when someone can reach a point of no return, whether it be from a concussion or just from headaches in general, where all options have been exhausted and the only option or the best option is to treat the pain through medication permanently?
Well, we certainly do have a number of individuals who found that medications have helped them tremendously. And if they choose to continue those medications and those medications are not causing adverse effects, then I certainly support that. To the premise of the question, no, I don't think there's a point of no return. That's not my overall philosophy. I tend to be an optimistic person, and I think that much like Teddy Roosevelt said, as long as you're alive, I'm paraphrasing, of course, but we keep fighting.
Yes, and I'm astonished by many things. I mean, I work in marketing and communication, so I'm not in the daily grind of treating kids and treating patients. But one thing I've always been mesmerized by is the brain. And I'm curious about how you became interested in your line of work in neurology and how you saw it then and how you see it now as far as the brain as just being this, for lack of a better term, this center of everything that goes on with the existence of a human being.
Well, the cardiologist might disagree with you there, but
that's true. But there's so much we don't know about the brain, and also there's so much that we can't do when things break down in the brain.
I think for me, I was looking for a challenge, and I don't mean this in a mean way, but some of what I saw in medical school seemed to be a little too routine for my particular makeup. And again, I don't mean that to be insulting to anybody, just that I felt I appreciated the challenge. I liked being in that position where there were still things to learn and questions to be asked, and frankly questions that I didn't really know the answer to. A big part of it was the mentors that I had, in particular Dr. Peter Huttenlocher at the University of Chicago, who unfortunately passed away a couple of years ago. But one of my goals eventually was to try to emulate him. I don't think it's possible. He was quite an outstanding physician, but I think for many of us, we find that we enjoy being with certain specialists. At least for me, I was in awe of what neurologists could do, and I sort of dreamed that maybe I could be somewhat competent and emulate them. But what I enjoy about my job is a couple of things. One is that I'm never quite sure what's going to be next. Mm-hmm. There is an awful lot of neurology that does not have to do with the brain. So we see spinal cord conditions, we see nerve conditions, we see muscle conditions. I like the wide range of ages that we see, and I especially like the challenge of trying to properly diagnose a particular child or adolescent, and figure out exactly what's going on, with the goal of trying to do my best to help and to try my best to help them be as healthy and as happy as possible.
Asking you what you think the next breakthrough in brain work would be an impossible question to answer, but what is the next breakthrough you're hoping there will be when it comes to working with the brain, either to make it better or to correct any kind of ailment or illness with it?
I saw some very interesting research results where neurologists are using magnets, and the magnets essentially shut off parts of the brain. And so if you take someone who's healthy and you put that close to the speech center, that magnet will cause a dysfunction so you're not able to speak. And it turns out that many adults, more likely than not, this applies to teenagers and children as well, when there is an injury, it is certainly true that some parts of the brain do not function well, but it's also true that other parts of the brain increase their activity, and that increased activity can often impede the normal function. So one of the more interesting studies that I've seen is where you have a magnet that's held up to that improperly firing part of the brain. That magnet decreases the activity, and then that restores the balance so the person is able to proceed. So that's one. The other very interesting thing that I saw recently is where, again, researchers are using computer technology, etc., so that people who've lost the use of arms and legs, or perhaps have had a loss of a limb and require prosthetic, where they're now able to use thought to make those limbs move, which is sort of neat.
It's fascinating. It's unreal that we've found out how, as much as we have in the past, even century, but what we continue to make as far as steps with treatment of any kind of physical ailment or disease, it's remarkable.
I think the main challenge for neurology is going to be that as the population continues to age, we're going to find more and more people with thinking problems, so-called dementias, and how we help people with dementia, I think, is going to be a very important challenge. And I think that if we're able to do that in a compassionate and caring way, that ultimately that's going to be good for everyone. The other challenge that we're going to run into is at the opposite end of the spectrum. As more and more babies survive prematurity, how are we going to help make sure that those very small babies do well? And so I think one of the challenges for neurology going forward is at the extremes, how we treat the very young, tiny, premature infants, and how we treat an aging population.
Before we say goodbye to you for the day, is there anything else you'd like to touch on as far as headaches go, headache management, and what parents need to know about it? This is so unique to me because there are so many, as you said, so many different symptoms, so many different ways that people can experience a headache. It's not just you have a broken arm, here's how we treat it. Well, if you have a headache, it doesn't quite work that way. What else should people know?
If professional help is needed, we're here. Please come visit us. I'd like to think that we can help. Secondly, if it is a power struggle, as my wife has taught me, you always have the choice of not picking up the rope. If it's a tug of war, two people have to be pulling on that rope. So if it's become a question where the child doesn't want to go to school and the parent chooses to enter into that power struggle, it creates it amplifies the problem even more.
Yes.
Our role as parents is not necessarily to be friends with our children; it's to parent them, to try to get them to a point where they can be independent and happy and healthy, without us micromanaging their affairs. And I think there's also there's also a certain degree of responsibility to yourself. And this is, again, I'm speaking mostly toward our middle schoolers and high schoolers, but you get to a certain age and we shouldn't have to tell you that it's time to go to bed or to do your homework or to eat a healthy breakfast or to get some exercise, or that all of the sugar in your Gatorade or all of the junk food that you're eating. There's a certain amount of responsibility that I think that I would encourage our middle schoolers and our high schoolers to take, to recognize that they can choose to lead healthier lives, and that is going to have a positive benefit in many different areas. And so So we tend to start in the headache clinic with how much sleep are you getting? What is your nutrition? How are things at home? How are things at school? What can we change? Where are the areas where we can make positive change that are not going to have any side effects like a medication would, and are going to help you be healthier? And wouldn't it be interesting if that had a benefit toward decreasing the frequency and intensity of your pain as well? So I do think that when the headaches are frequent and severe, it affects the entire family, and there are decisions that parents and the individual and perhaps even friends and siblings can make in order to try to make positive change so that person can get back to health.
Well, we appreciate the time and the information. Enjoy the rest of your day.
Thank you very much.